Good evening, everyone. I'm Kriti Joshi from the Department of Endocrinology at AIIMS Rishikesh, and I'm going to be talking about beta cell preservation and replacement in type 1 diabetes. So first of all, why exactly are we discussing this problem? Now, we know that type 1 diabetes is a problem all around the world. There are more than 1 million children affected by this condition around the world. And this is quite particularly relevant to our country, India. And we know that this is because just by virtue of our sheer numbers, we actually have the largest population of children living with type 1 diabetes in our country, so about 100,000 children. We know that in spite of our best efforts and technological advances, type 1 diabetes still remains a condition which can be treated but cannot be cured. And therefore, these children still remain at a lifelong risk of developing micro and macrovascular complications. And at the same time, the cost that it has on their quality of life, of course, cannot even be counted. So therefore leads the concept of efforts at prevention and preservation of beta cell function. So that's one of the good things about type 1 diabetes, that it's amenable to possible prevention and preservation strategies. And just going back to the previous talk by Professor Bhatia, which talked about the immunology of diabetes, we know that type 1 diabetes has actually got a long pre-symptomatic phase. And this is the time where we can actually intervene with either our prevention or our beta cell preservation strategies. Even when individuals become symptomatic with clinical type 1 diabetes, there can still be attempts at trying to replace the lost beta cells or trying to preserve whatever remaining beta cell function there is. But this is probably easier said than done. And that's primarily because the disease itself is a complex beast. We still do not quite understand it. What we do know is that there is an imbalance between immune activation and immune regulation, and the activation overwhelms the regulation. This typically occurs in individuals who are already genetically predisposed to have the disease, and there are some kind of environmental factors which trigger off the disease, but these factors are still not very well known. So what are the unknowns? Now, the basic thing is that the pathogenesis of the disease is yet unclear. Most of our knowledge still comes from mouse models of the disease, which are imperfect mimics of the disease in human beings. We don't exactly know all the triggers which actually set off the autoimmune process in type 1 diabetes. And therein lies the big problem, that if we're trying to avoid the disease, we first need to understand what sets it off. And we don't exactly understand that as well. And then most importantly, with more and more knowledge coming out, we're becoming aware that the disease itself is very heterogeneous. There's no one size fits all for type 1 diabetes, and there's a lot of individual variability. So every individual progresses through the disease process in a different way, and therefore perhaps might have to be targeted in a different way as well. So whom do we target? That's the big question. And that's where the whole concept of type 1 diabetes prediction comes in. So we clearly need to only target those individuals who are at a high risk of progression to clinical disease. So therefore, we need to have good prediction strategies. And we know now that those individuals who have high risk HLA alleles and or the presence of autoantibodies are at a high risk of progression. In fact, the presence of 2 or more than 2 autoantibodies virtually guarantees that there will be the onset of type 1 diabetes sometime during that individual's lifetime. And these are typically the starting points for entry in most trials. And we understand that there is a pre-symptomatic phase which allows us to intervene. So there are various time points that we can actually sort of intervene and prevent the disease from happening. So we've got these first group of individuals who are just genetically at risk but are still well, and there's no evidence of autoimmunity. So that's where we can intervene with our primary prevention strategies. In those individuals where the autoimmune process has already started, that is, they have evidence of autoantibodies plus minus dysglycemia, we can target them with our secondary prevention strategies. And then finally, in those who have already developed clinical disease or are symptomatic, we can try and attempt tertiary prevention or preservation of residual beta cell mass. So starting first with our primary prevention trials. Now, the first thing that we need to understand is that these individuals are essentially healthy individuals. They just have a likelihood of development of disease, but are currently disease-free. And therefore, we have to be absolutely sure that any intervention that we're trying in this group is absolutely safe. And therefore, what has mostly been used in these groups is basically just modification of the various risk factors or triggering factors, most of which have been diet related. Of course, these studies are hard to do because you've got to follow up these individuals for a very long period of time to see their risk of development of diabetes. So of course, they're difficult, expensive, and time-consuming studies. So let's look at what are the agents that have been used for primary prevention. As I said earlier, it's mostly dietary agents that have been used, agents which have been associated with risk of development of diabetes. And the particular putative agents which have been discussed are avoidance of early cow's milk, avoidance of plant protein and gluten, omega-3 fatty acid supplementation, and insulin supplementation. Let's just look at each of them in a little bit more detail. So cow's milk is one of the most studied sort of agents in this area. And this is because there have been retrospective studies which have linked duration of breastfeeding or early exposure to the cow's milk protein to autoimmunity. And it's believed that there may be some components of the milk which are molecular factors that may act similar to human insulin, and therefore through the process of molecular mimicry might act as triggers for the islet autoimmunity. So I think I'm just going to discuss the major trials in this area because there is a lot of information, and the trigger study is the big study in this area that really needs to be discussed. This was basically a large study that a double-blind randomized control trial, which was a multi-centric trial done in more than 15 countries, enrolled more than 2,000 children, one to a placebo arm, which had children being weaned to a normal formula, and the other arm in which the children were weaned to an extensively hydrolyzed formula, which basically did not contain the cow's milk protein. So it basically was designed to answer the question whether weaning to this extensively hydrolyzed formula decreases the risk of type 1 diabetes or autoimmunity later on in life. And this was based on the results of a pilot study that had actually been positive. But I think, as you can all clearly see in the results of the survival analyses, with the casein hydrolysate group in the solid lines and the control group in the broken lines, there was actually no difference in the risk of development of autoantibodies in this group at the end of the study. So this was essentially a negative study. It did not find any effect of avoidance of cow's milk protein on development of islet autoimmunity. As I just said, gluten was the other molecule where a lot of interest has been focused, again, because of previous observational studies, which is mainly retrospective analyses data from the DAISY and the baby diab study, which basically has found that either early or late exposure to gluten both increased the risk of development of islet autoimmunity. And this again was similarly tested in an intervention trial. This was the baby diet study, which came out in 2011. And this was an open label trial where 150 infants were randomly assigned to either gluten exposure at the normal age of 6 months or a late exposure group at 12 months. And again, what you can see here is that the control group is in the broken lines and the late exposure group is in the solid lines. And I think, again, it's fairly obvious that there's no difference in the development of islet autoantibodies between both these groups. So again, a negative study disproving that there's any role of gluten exposure or delaying gluten exposure in the risk of islet autoimmunity. So just summarizing what has been done in the arena of primary prevention, we learned about the trigger study, which was a negative study and did not find any effect on islet autoantibody development with the use of an extensively hydrolyzed formula. Similarly, the baby diet study, which tried to delay gluten introduction in children, also did not find any delay in development of islet autoantibodies. There's been one positive study, the FINDIA study, which came out from Finland, which studies the elimination of bovine insulin from infant formula, which led to a delay in the appearance of islet autoantibodies in this high-risk group. But this was a small study, so we don't know if the results can be generalizable. Other agents that have been tested are omega-3 fatty acids and vitamin D, which have not uniformly found to be effective. And then there's a big trial, the POINT study, which is testing oral insulin in these high-risk infants, but the results for that are still awaited, so watch this space. So moving on then from primary prevention to secondary prevention. So now this is a subgroup which is at a high risk for disease. They already have evidence of islet autoimmunity. They might or might not have dysglycemia. And we're trying to prevent progression from the autoimmunity or pre-symptomatic stage to overt type 1 diabetes. And there are basically two avenues that we've got. There can be antigen-specific interventions or non-antigen specific interventions. So just try to understand this a little bit better. Let's just go back to our understanding of the immunology of type 1 diabetes and the events in the endocrine pancreas. Now, as we know, the initial process starts with the process of beta cell death, which is triggered by some triggering factor, still as of yet quite unknown. There are islet autoantigens which are released, which are picked up by antigen presenting cells in the islets. These are then presented to T cells, which leads to T cell activation. These autoreactive T cells infiltrate the islet and lead to beta cell death. There's similarly B cell activation as well, when these B cells later on lead to production of islet autoantibodies. So basically, we can intervene at all of these points. So we can intervene with the use of antigens, which can be antigen-specific interventions, or we can intervene at all of these immune activation stages. So we can intervene at the antigen presentation stage, at the T cell activation stage, or the B cell activation stage, hoping that this will halt the process of further immune activation. So these are the interventions that have been tried. So antigen-specific interventions can be used in effect to induce tolerance. Non-antigen specific interventions are basically aimed at lymphocyte targeting. So they basically try to inhibit the lymphocyte activation in type 1 diabetes. And the agents that have been used are anti-CD3, which inhibits T cell activation, CTLA4 immunoglobulin, which again inhibits T cell activation, or anti-CD20, which is, we know very well, is a B cell activity inhibitor and inhibits B cell activation. And then we can also act on the cytokine side of things, so using usage of anti-inflammatories like anti-IL-1 or anti-TNF alpha. So let's start with the antigen-specific interventions, and insulin is the main molecule that has been studied here, mostly because insulin is believed to be the most potent autoantigen both in animals as well as human models. And the whole principle of antigen therapy is that we're trying to induce a state of tolerance by repeated exposure of the immune system to that antigen, so that in the future, when there is exposure to the same autoantigen, the body is already immune to it and does not react in the same way. So the DPT, or the diabetes prevention trials, were big trials that were carried out in high-risk individuals that studied the use of oral or parenteral insulin administration to try and prevent disease onset in this high-risk group. But unfortunately, this was the whole cohort actually found that there was a negative trial, and you can see here, this is data from the DPT oral insulin arm with the treated group in the solid black line and the control in the broken line. And this shows the risk of development of development of diabetes, and it was no different in both the subgroups. But there was an interesting data that came out of this study, and this was when they tried to do a subgroup analysis, and they found that the group that had higher antibodies to insulin or higher autoantibody levels, there was a suggestion of a benefit. So in that subgroup, there was a reduced risk of diabetes development. And this then led on to the larger study, the TrialNet oral insulin study, which was the bigger study by the TrialNet group and was adequately powered to answer this specific question. But again, this study was conducted in high-risk individuals and used oral insulin. This was a randomized control trial, trying to look and see whether oral insulin supplementation prevented the development of diabetes. And again, in the whole subgroup, I think you can easily make out the oral insulin arm in orange, the placebo arm in black. And this just shows time on the x-axis and shows the proportion who went on to develop diabetes. No different in both of the groups. So oral insulin did not prevent type 1 diabetes in the primary cohort. But again, in this cohort as well, when they tried to do a subgroup analysis of a group of individuals who were probably more high risk or had a higher degree of progression or autoimmune activation because they had a low first phase insulin release, they again found that there was a difference or a delay in development of diabetes in the group that was treated with oral insulin. So even though overall negative studies, but still important information coming out from these studies and perhaps proving the point that this is a heterogeneous disease, everybody does not behave the same way, but there might be a specific subgroup, niche group of patients who might actually respond to this form of intervention as well. But then the really sort of interesting and positive data that has come out has been in the non-antigen specific intervention group. And this is with the use of lymphocyte targeting, with the use of this anti-CD3 antibody called teplizumab. This was published by Kevin Herold in the New England Journal last year. Really striking results where they enrolled individuals with high risk of type 1 diabetes, treated them with a single course of teplizumab in blue versus placebo in red. And I think the results are obvious there for anybody to see. Teplizumab significantly reduced the risk of diabetes and delayed onset of diabetes by 2 years in the treatment groups. This was one of the first trials which has shown such a striking result. So very encouraging results there in this group. So just summarizing what has been done in the secondary prevention trials, the antigen-specific interventions have not uniformly been successful as seen by all of the insulin trials, but there is a delay that has been noted in some high-risk subjects. So perhaps we need more studies in this area. There are still more studies which are going on intranasal insulin. GAD-alum again has not been found to be successful, but there's still more data that is awaited in this area. But the really interesting data, which we just saw, came out from the anti-CD3 teplizumab group, which led to a significant delay in progression of diabetes. And there are other studies by the TrialNet group on the use of the CTLA4 immunoglobulin and hydroxychloroquine, the results of which are still awaited. So again, we need to watch this space for this data. And then finally, we move on to tertiary prevention, which is a kind of prevention strategy that we use in individuals who are already symptomatic with the disease. So they can be either the ones who have recent onset of disease, which is onset of disease less than 100 days. And this is where we can use both immunosuppressive or immunomodulatory strategies in an attempt to try and prevent further beta cell loss. Because now there's more and more data coming out that contrary to prior information that more than 90% of beta cell mass was lost at the onset of diabetes, that's no longer true. And the older the individual is, there's more likelihood that beta cell mass, a significant degree of beta cell mass might still be remaining even at the onset of clinical diabetes. So there can certainly be an attempt to preserve that. And then in those who have more established diabetes where limited beta cell mass remains, there can be attempts at trying to regenerate the islets or replace what has been lost. Now, one important point to remember is that because we have no good markers of beta cell function or beta cell analyses, all that we rely on as an endpoint to all of these studies is the measurement of C-peptide. And that's important because this is only a surrogate marker of beta cell function. So that's a point really to be remembered. So the whole saga of tertiary prevention really began way back in the 1980s with the use of the cyclosporin trials. which were effective, by the way. It did show that there was a delay or prolongation of the honeymoon period and even insulin independence in some individuals with the use of cyclosporin. So this proved 2 points really. One was that this is an immune-mediated disease, and second was that immunomodulatory or immunosuppressive strategies work in type 1 diabetes. Another important point that was also proved, however, with these trials was that the effects of these medications are extremely short-lived. So the moment the medication is stopped, the effects reverse. And of course, the side effects are significant. So these were, of course, not feasible to be carried on long-term. So from there, then we move on to the current era, and let's look at the strategies that are being used currently. So for beta cell preservation, there are, again, similar to secondary prevention, there are antigen-specific approaches, where similarly autoantigens such as proinsulin and GAD are being used. But again, the major targeting or major focus remains on lymphocyte targeting with the use of anti-CD3, CTLA4 antibodies, anti-CD20 or anti-thymocyte globulin, all of which basically act to damp down the immune response, inhibit T cell activation, and prevent further beta cell loss. And the third area in which we can intervene is basically inhibiting the inflammation in the pancreas with the use of these anti-cytokines like anti-TNF alpha, anti-IL-1 beta, and interleukin-1 receptor antagonists. Now, most of this, as we can see, is focusing on trying to reduce the immune activation that we know occurs in type 1 diabetes. But if you remember some of our earlier slides, the other problem in the whole process of type 1 diabetes is the dysfunction of immune regulation. So that's the other side of things which we could also work on. And that's where the whole concept of enhancement of the regulatory function or the tolerance capacity of the body comes in. And that can be with the use of interleukin-2 or GCSF, which enhances the T regulatory cells of the body, which again act by suppressing the immune activation. And then we can have the use of cell therapies, which basically work the same way by boosting the body's immune tolerance capacity. So again, there's a lot of data here, so I'm not going to be able to talk about all of them. So I'm just going to talk about the tertiary prevention trials that have been successful there, because there have actually been a lot of things that have not been successful. They've been successful in mouse models, but not really in human models. So really the agents that have worked in human type 1 diabetes is most of the ones which target lymphocyte activation. So similar to the secondary prevention, teplizumab or anti-CD3 has worked. Rituximab, interestingly, a B-cell targeting antibody or anti-CD20 has also worked. Abatacept, which is the CTLA4 immunoglobulin, has also shown a delay in decline of C-peptide. There's been recent data from Haller's group on the use of anti-thymocyte globulin, which has also shown improved area of curve of C-peptide. Now, again, we must remember, and going back to the same point, that the end point of all of these studies is a delay in decline of C-peptide. And that brings me to our next slide. So before we become too hopeful and start rejoicing, we must understand what exactly are we measuring here? What are we becoming happy about? And as we said, the measure of our success is really an indirect measure of beta cell function, that is C-peptide, or area under curve of C-peptide. And this is just because we do not have any better measures of beta cell function or mass at this point of time. And really, if you go back and look carefully at all of these trials, what has been demonstrated by most of these studies, interestingly, is that the use of these agents basically leads to a sort of a plateau phase where the beta cell decline is halted for a short while, perhaps 12 months, 24 months. And then there is a fall in beta cell function in the therapy group similar to the control group. And in fact, the rate of decline is often found to be similar in both of the groups. So we must remember that none of these trials have been able to demonstrate insulin independence, which would really be the gold standard, or a reduction in insulin requirement, and even improvements in glycemic control have been very plus minus with all of these studies. However, the good point to take from all of these studies is that at least with all of these latest drugs that are being used, it's been found that they have a prolonged effect. So a single dose or a single use is still leading to prolonged effects after a year or even 2 years, which is encouraging, which basically means that even if the patient has to come back for top-ups of the drug once in a year or once in 2 years, that's still all right. And the other thing to be remembered is that most of these drugs have been found to be relatively safe. They're leading to some degree of lymphopenia, but there are no severe side effects that are occurring in most people. So is it all doom and gloom? Not necessarily. We know that there are challenges, but there are potential solutions there as well. And I think one of the biggest challenges that we need to come to terms with and work towards is that we still do not understand the disease. We're trying to cure something without really understanding its pathogenesis. And that's mainly because the disease itself is complex and we haven't really had access to human tissue till now. So most of our knowledge has come from animal models. Now, with the availability of stem cells to create disease models, lots of collaborative biobanks around the world, which are bringing out more and more data of human disease. Hopefully, our understanding of the disease will become better and allow us to design better studies. The other second important challenge is that, as we just discussed in detail, we do not have good disease biomarkers. We're still relying on things like development of autoantibodies, development of clinical diabetes, and C-peptide preservation. So people are again trying to look for potential solutions here. So people are now studying the use of proinsulin, beta cell death assays, and better measurements of beta cell mass, which might allow us to have perhaps better endpoints for all of these trials. And then finally is our understanding and our realization about the heterogeneity of the disease, that the disease process itself is not similar in two individuals. There's no one size fits all. Therefore, we're going to have to use tailored therapy. Monotherapy is probably not going to work. We're going to have to use combined therapy. And the other thing that we may have to come to terms with is that chronic immunosuppression or immunomodulation may be needed in type 1 diabetes for inducing remission, very similar to what is done in most other autoimmune diseases. So from there, let's just briefly talk about cell-based therapies. We know that there are a lot of cells in our body which have tolerogenic properties, which can basically reinduce a state of self-tolerance and damp down the immune system. And this can be done with the use of cells such as tolerogenic dendritic cells, T regulatory cells, and cord blood cells, all of which do basically the same kind of job. Now, most of the data on dendritic cells and T regulatory cells is still from phase 1 and phase 2 trials. So we are still looking for more robust data here. Cord blood has been found to be not useful in stage 3 trials, but there's still more trials going on, particularly in Australia, the cord study. So we look for more data in this area, certainly in the upcoming years. Now shifting gears a little bit to the more interesting area, which is something that all of our patients are interested in, and so are we, which is the arena of stem cells and how they might modify the whole environment of diabetes and treatment of diabetes in the future. So what can stem cells do? They can certainly be used for creating new beta cells to replace the ones that have been lost. And this can be done using pluripotent stem cells or embryonal stem cells. However, they can also be used for immunomodulation and preserving beta cell mass and function. And this can be done using hematopoietic and mesenchymal stem cells. So let's first begin with hematopoietic stem cells, which are the only ones that have been tested clinically yet. And the whole principle behind using them is that we're just trying to reset the immune system so as to reinduce a state of tolerance of the body to the beta cell autoantigens. Now, these are the big trials, which I think everybody knows about, which came from Professor Walterelli's group in Brazil and were published in JAMA in 2007 and 2009. So point to be remembered, this is the only form of therapy that has been shown to be effective in leading to insulin independence. And this group just published their 30-month follow-up data. And strikingly, 50% of their patients managed to retain insulin independence. But there's a big but here. We must remember that what they did in this study was that they had to use cyclophosphamide to mobilize the hematopoietic stem cells from the bone marrow, which were then autologously transplanted back into the same individuals. And the use of this immunosuppressive therapy caused pretty catastrophic side effects, in my opinion. So a staggering 40% patients, so 9 patients developed oligospermia, and 2 in fact developed nosocomial pneumonia. So on the one hand, while this is the only stem cell therapy which is shown to be effective, we must understand that it has been associated with big side effects. So it's really not feasible to apply this to the general population. So we're looking for perhaps trial systems which include less toxic mobilization regimes. Mesenchymal stem cells is another type of arena. This is a type of adult stem cell that can be isolated from bone marrow, umbilical cord blood, etc. And again, the potential that they have is that they have immunomodulatory functions, so they can damp down the immune response. But again, most of the data in this area is preclinical. There's a lot of MSCs in clinical trials at this stage. And there was a small trial which was published in 2015, which did show a preservation of C-peptide function, but small data there. So we're looking for more robust data in this area as well. So we finally come on to our pluripotent stem cells that are basically used to regenerate or create new beta cells. So where these cells can come from is they can come from donated IVF embryos, and these cells are derived from the inner cell mass of the blastocysts, and these are the embryonal stem cells. Or you can reprogram adult cells by adding certain reprogramming genes, which basically de-differentiates them to a state of pluripotency. And this leads to generation of pluripotent stem cells, which can basically then be differentiated to any adult stem cell type from any tissue or organ. And you can certainly generate beta cells from them. So what do we do? It's actually very simple in theory, not in practice. So what we're trying to do in vitro is we're trying to mimic the process of fetal organogenesis of the pancreas in vitro. So what is done is that a combination of growth factors is used to guide these pluripotent stem cells through various definitive developmental stage to finally lead to a mature beta cell. Now, as I said, in theory, sounds very attractive, but is it as easy as I said it is? Not really. This is a complicated process, and a lot of academic centers have used protocols to generate lots and lots of more and more mature beta cells, but really most protocols are still generating very immature beta cells, which only manage to functionally resemble fetal beta cell rather than adult beta cells. We still don't know the lifespan of these beta cells. There is a risk of teratoma formation with the use of any stem cell therapy. And then finally, and most importantly, these cells are beta cells in the end, just like native beta cells, and therefore are still prone to the risk of autoimmune attack, which basically means that regenerative strategies need to go hand in hand with immunomodulatory strategies at the same time. So to protect them from the immune system, these are the kind of sort of cell containment pouches that have now been developed, which are semi-permeable barriers, which allow nutritional inputs to come in and insulin and other hormones to leave this pouch, but manage to keep the immune cell out, therefore sort of preserving these cells from the immune attack. And most of this work is being done by this company called Viasite.com, which has actually even started clinical trials in this area. And this is the name of their product, which is in clinical trials right now, which does not need any immunosuppression. So very, very exciting area of research. So watch this space again. So just to summarize where we're at, prevention of beta cell loss still appears to be an elusive target. While immunomodulation has shown short-term C-peptide preservation, these results have been transient, so we need to be cautious when interpreting these results. Again, all of these endpoints are basically just C-peptide, so we really don't know how well it translates clinically into quality of life, as well as prevention of micro and macrovascular complications. And really, we need to understand that the first step in designing better trials will be understanding the disease better and understanding the disease pathogenesis better before we go on to do more and more complicated studies. And we again need to come to terms to the fact that we probably will need to use combination immunotherapy in the future, and patient-tailored therapy is going to be the direction of the future. And stem cell therapies are an exciting new area where we're working towards, but there's still some hurdles that need to be crossed before this can be translated into human use. So with that, I end my presentation. I thank the organizers for allowing me this opportunity, and I'm happy to take any questions if there's time. Thank you very much.